on the red points that I have for you on these PowerPoints. So supine position, our centering is going to be 2 inches above the upper border of the pubic symphysis. Very important. But at the level of the symphysis when we're doing voiding studies, this comes in 2 varieties, a plain cystogram and a voiding cystogram. Regular cystogram, we do not actually visualize them urinating, but voiding cystogram, we do watch them urinate. So same exam, 2 varieties, regular versus voiding. So regular cystogram, 2 inches above pubic symphysis, voiding at the level of the pubic symphysis because we want to be a little lower to visualize that bladder and the urine and the contrast exiting the urethra. So 15-degree caudate angle. By the way, very great question here. Why are we angling 10 to 15 degrees caudate for this exam? Why specifically? Why don't I go cephalic? Because wouldn't the cephalic like stretch out the bladder? What y'all think critically?
Would it position the bladder higher than the pelvis?
Not exactly. There's one specific reason. What Monsi just said, you want to move the pubic symphysis out of the way. So utilizing that caudate angle is going to specifically move that pubic symphysis more inferior and give us a full view of the entire bladder without superimposition. Please put a star on that fact. Very important point. We angle 10 to 15 degrees caudate to specifically move the pubic symphysis out of the way and get a full visualization of that bladder. So central ray will be entering once again 2 inches above pubic symphysis. They'll be at the level of pubic symphysis for voiding studies. And we're going to be using a 10 by 12 lengthwise cassette for these exams. 10 by 12 lengthwise cassette. Now the reason you have the range, by the way, fun fact, if they have a lot of lordosis going on, you're going to use a higher degree of angulation to make up for the lordosis in the lower back. But that's of course not very common. That'd be for special cases. So a lordotic back, you want to increase your angle because they have an increased curve on their lower back. It's going to actually angle the pelvis a little more naturally. So you need to utilize a longer or larger angle to compensate for that curved back.
That's a smaller angle. That's a smaller angle.
I'm sorry, smaller angle. Sorry about that. I'm talking backwards here. Thank you. Good eye. Smaller angle for greater lordosis to compensate for that curve because it's naturally, I did say that point, it's naturally angling the pelvis when you're lordotic. So you don't need the angle. Wasn't that weather lovely this weekend though?
Yes.
Isn't that nice? Took the kids to the zoo, it was so pretty.
Oh, that's perfect.
Can you see?
It was on Saturday, I hope
That was funny.
not. Yeah, if you're a certain student who I won't name from last year, apparently they did that all the time in that class, thus a lot of issues I was just talking about.
Was it Gus?
Hmm?
When you said Gus?
Was it y'all? No.
No, was it
Gus?
Gus.
Like Gustavo?
Because you said Gus.
Hey,
So I do it.
hey, we know who it was.
You can probably figure out who it is pretty easy.
Do it.
If that was indeed true. I couldn't tell if they were trolling me or being serious.
No, they went.
The
They
zoo
were-
was expensive.
There were pictures. They went.
Really? Because the zoo's expensive.
Oh, yeah.
They had money to blow.
It's like $35 a person to get in the zoo.
No.
That's why we buy annual pass there. Fun fact, guys, for my Houstonians around here, if you're going to do the zoo, get the annual pass because you basically paid for it in one visit anyway if you have multiple people with you. You can take 10 people with you for one annual pass.
That is it?
Mm-hmm. Buy you one annual pass, you can take 10 people with you.
Thank you.
Just get everyone to divide up the price.
Appreciate that.
Save you a ton of money.
I think that's
So what, y'all get like all kids together? Like all the...
We usually divide up with my sister-in-law. We divide the price in half, and she can take her kids, we can take our kids all together. All right, so what are we looking for on an apiaxial bladder? Well, I hope we're looking at the bladder because it's in the name. So bladder filled with contrast. We want the distal ureters to also be visualized because we're also going to check for that reflux if it's occurring. Pubic bones below the bladder neck and proximal urethra. How do we achieve this? By that angulation, correct. And contrast medium in the bladder, distal ureters, and proximal urethra as needed. We're not really going to worry about the urethra if we're not voiding. unless they have some incontinence issues and it's just leaking out. But we'll definitely be worried about it if we are watching them void. Yes?
So for the distal ureters, that's only gonna be shown if there's a reflux?
Correct. Because
Okay.
it should not be flowing back up to the kidneys. That's an issue if it is.
Okay.
Your bladder should just be able to hold that in place without it going back up.
So it should.
Reflex into the ureters would be a bad thing.
So that means it would be going.
All right, so now we have our oblique positions, of which we have two that we're going to do. We're not going to do REO and LEO, but we're going to do an RPO or LPO. That will be up to the doctor, by the way, to decide which oblique he's going to do. He doesn't necessarily have to do both, but one or the other. He's also going to do an oblique in a range of 40 to 60 degrees. Please make sure you're making note of these obliques, guys, because you'll notice in this whole chapter, nothing's really strictly 45. Everything has a range to it. 40 to 60 on the bladder, 40 to 60. Centering will be 2 inches above that upper border of the pubic symphysis once again, and 2 inches medial to the upper as is to compensate for the upside or the oblique part. So 2 inches above the pubic symphysis, 2 inches towards the upside or medial to the upper as is.
So 2 inches needed to the upper as is.
Watching a movie next door?
A lot of time.
They're having a popcorn party, right?
It's sonography awareness. So like their Rad Tech week almost for Sono.
That means we get to watch a movie?
We're gonna have fun during Rad Tech week.
You sure?
Absolutely.
You sure, Mr. Donahue? You sure?
On the show.
Oh, okay.
Are we still? We're still allowed to wear
Yes.
school-friendly costumes on Halloween, right?
Sorry?
We're still wearing school-friendly costumes on Halloween. Right?
Unfortunately, we could not get that approved. I'm glad you brought that up. The big man said no.
Headbands?
He said no to everything.
No clips?
No type of dress up. We can decorate the room, but we can't do dress up.
No
Man,
clips?
I was a whole
That's
skeleton
what I
last
do.
time.
I know.
No clips in
He doesn't
the
want
hair?
any. He doesn't want any
Wear
dress up
clips.
this year.
No clips in the hair, no nothing?
Well,
He don't got no hair, that's why he's so.
I don't know
We
why.
tried. We tried.
We'll decorate this room, all right, though.
Stand.
Does he have an armpit?
And he
He does.
Hey, let's,
Go to TP's office. Right down the hall. Right down the hall.
Mom, just fancy
It's the doorway right after security. Doorway right after security.
Yeah, so you can't TP. You can TP him though.
It's locked. You can't get in there. Unless you have my
They have to let
Oh,
you. I guess we have to jump.
I might just let this fall on the floor though. No, unfortunately, guys, not happening. He wouldn't give us the go ahead on that this year. But if y'all still want to do some kind of festivities as far as like food and decoration, you can still do that. He just doesn't want anybody dressed up.
We didn't dress up, so we just broke out.
All right, moving on, guys. Central ray, like we already talked about, 2 inches above the pubic symphysis towards the upside. We also, in order to visualize that bladder neck and proximal urethra, we're going to utilize that 10-degree caudate angle to project those pubic bones below to give us that clear visualization like we already talked about. And if we are doing a voiding study, we will once again go a little bit lower, being at the level of the pubic symphysis to get a better look at that urethra. 10 by 12 lengthwise cassette, same as the AP axial.
So if we're not looking at the bladder neck and proximal urethra, then we're not even?
Say again?
For this oblique, are we even or no?
Only if we're specifically looking at bladder neck and proximal urethra, they're going to use an angle. That's very uncommon to do so. You're just going to usually use that perpendicular central ray. That's a very specific case.
Which one was the 30 degree? Did you 30 degree?
Not for bladder.
No,
Not for bladder.
but those are pretty close. Is there another oblique?
We talked about other obliques, yes.
Is it IBU?
I think IVU was like a 30 to 50, 30 to 45, something like that. In the obliquity. All right, so obliques projections of the bladder with contrast. That's the star of our show. And if there is reflux, of course, we're going to see those distal ureters visualized. But hopefully we're not seeing that because that'd be a bad thing. That means they're very sick. They're having some major renal difficulties.
I
Are they doing these positions just so they can see every possible, I guess, profile of
Yes.
the bladder?
Yes.
Will they do both? Like both?
It depends on
like-
what the doctor wants. Typically just one, but he may ask for both. And usually these are all done under fluoro. You're not doing the plain films like we're learning about here.
Okay.
These plain films are very rarely done anymore in
They
fluoro,
did
as y'all
them
as y'all
yesterday.
know. Hmm?
They did plain film.
Oh, they did.
Yeah.
So they do. Okay.
Yeah, they did them
Well, there you go.
yesterday.
There you go. Depends on what the doctor wants.
On the lady they did, but on the man they did.
It's
So-
per physician request, basically,
Probably.
on plain films or fluoro. All right, evaluation criteria: distal ureters, if present, bladder and proximal urethra, and of course, contrast medium in the bladder, ureters, and proximal urethra specifically. Pretty easy to remember what we're looking at. It's in the exam name: bladder, cystogram. Ureters, urethra, and bladder. That's what we're focused on. And of course, we still want to see those pubic bones out of the way if possible. Usually with this oblique, they're naturally going to fall out of the way.
Can we watch a movie? We didn't get to do that part.
Y'all would rather watch a movie and not learn what's going to be on your test? Because I'll gladly not talk anymore.
Which one is less than? This one?
The right hand needs to more.
One is less than.
Less
go to the
than
right,
is one
go
that
to the
looks
right.
like L.
This is left?
Less
Yeah.
than looks
Going
like
to the
L.
right is less than.
Oh, less than.
Less than looks like L.
Oh, okay, okay.
What are we-
Shaheen, that's how I remember
what
it
are we
too.
talking
Yeah,
about?
less than
Oh,
looks like L.
Okay, that's
Less
good.
than
I'm proud of
is-
that.
Whichever
Throw up
the
them
button-
signs,
whichever
Shaheen.
the button is
Throw up your
on.
sign.
All right, guys, if they are, by the way, this was for regular cystograms. For voiding cystograms, where we have them actually urinate the contrast out, here's what we're looking for. Entire urethra, keyword entire urethra filled with contrast, and urethra overlapping the thigh for improved visibility. Now that's going to be specifically for males, because you can't overlap a female's urethra on her thigh. Unless you pull it out, not going to happen. Not gonna happen. But for males, you can actually position the penis on the thigh to get the entire urethra, because the male urethra is more complex than the female. But you do want to put it on the thigh. So they're basically gonna, this is where it can be kind of uncomfortable when they're doing the voiding, guys. You want them to basically pee on their leg. For males, you're gonna make them pee on their leg, on their thigh. But it gives you the best visibility of the urethra.
So we're only looking at the urethra first?
For voiding, for
Or
voiding.
bladder and.
Bladder and urethra specifically. And you can ask the patient to do it for you. You don't have to necessarily do it for them unless they're unable to.
Positioning them?
The positioning
And
of the organ, yes. All right, and then finally the lateral bladder. This is gonna be a lateral recumbent, right or left, depends on what the table, which way the table's facing and or how the doctor wants it done. Centering is 2 inches above the upper border of the pubic symphysis, same as the other ones we just talked about. And you'll notice we do have something behind the waist. Y'all remember this thing? What is that?
Absorbs the,
Lead shielding for what?
for absorbing the scatter.
Absorbing the scatter, correct, because very thick area, there's gonna be a lot of excess scatter, it's gonna really take away from the image. It does make a difference. Despite what your text might tell you, it does make a big difference on your image quality. Please use those shields behind the back. It really does help.
Especially if they're thicker.
It really does make a difference. New saw. Probably think that's classroom appropriate, but okay. All right, central ray, no angle, guys. Perpendicular, 2 inches above the upper border of that pubic symphysis once again. 10 by 12 lengthwise. Now that has changed. So your centering is basically the same for all 3 of those views, guys. Unless you're doing a voiding study, which you go a little bit lower. And And of course, we want to see the bladder filled with contrast, and if there is reflux, distal ureters. So the evaluation criteria is basically the same for all three of these as well. Ureters, bladder, urethra. In ureters, you're only going to see if there's reflux present, which would be a bad thing. We don't want to see reflux. That is that patient is very painful. It looks like they put their marker in the rectum there.
It probably
The same
did.
spot. I would put it in the front personally. Actually, you might not want to put it in the front because it might get peed on.
Decisions.
Yeah, decisions. You want fecal matter or urine on your marker? That's the greatest choice in life. Soft tissue cookies.
That soft tissue just.
Barium enema in the front, bladders.
Soft tissue cookies. I've heard that one.
Hey, I would
There you go.
just throw it on throw it in the glove, you know?
There you go. Put it in the glove.
Yeah, put it in the glove.
Work smarter, not harder. Same thing, guys. Eval criteria. Distal ureters, bladder, proximal urethra, contrast in those structures as well. That's a very full bladder, by the way. That person needs to, yeah, that's like maximum.
Is it possible for it to
Rupture? Of course it is. It's like a balloon. A lot of people have really bad trauma to their pelvic region, like childbirth, wrecks, etc. They literally get like tears and holes in their bladder. It leaks out to the recesses. Of course, that can be very toxic for the inside of the body, causing lots of issues. Very easy organ to damage. All right, so let's talk about our last two exams. Male cystourethropy. You'll notice that male is separated from female because the male positioning is going to be different than the female because of that more complex male urethra. So this usually precedes an endoscopic examination. And we have only one essential projection for cystourethropy, by the way. What's this a study of based on the name? Bladder and urethra. Please make sure you know that. We're going to do the AP oblique specifically. That could be an RPO or LPO to demonstrate that bladder neck and urethra with as little bony superposition as possible. We're not going to do an AP. We're not going to do a lateral because this is a functional study of the urethra specifically. And the best way to see the urethra is with the urethra placed over the thigh of the male patient in that oblique position.
So if you place it on the thigh, it's already in the oblique position, sir?
I'm sorry?
If you place it on the thigh,
Well, you need to
it
roll.
ends up-
You need to oblique the
Oh, you
patient.
have
You
to
just want to
oblique.
make sure the urethra is on the thigh. So you might have to help the patient out there if they can't do it themselves. Oh, you set up for the wrong career if you can't do that.
They're not paying you extra for it, that's all I'm saying.
What'd you say for what?
What if they're passed out or what if they're special needs?
I'm gonna
With
put
their,
that thing right
baby.
on the thigh, you know what I'm saying? Twice about.
They got special needs. If they need, I'm sorry.
I'm just saying you don't know what your patient condition
That's
is.
so
You might have to
messed
So
up.
is
assess.
she gonna be moving all manner
Take
of
us-
body
Huh?
parts?
Tape it. You can tape it.
Oh, yeah.
Tape it.
No.
Just be careful when you pull the tape off.
Uh-uh.
Okay, so
She gonna
position
damage the soft
will be a
tissue.
supine RPO. What'd you say?
She gonna damage the soft tissue.
Yeah, don't rip that tape
No,
off.
I just sit it there, just sit it, don't take it.
Yeah,
Let it be
something you don't
like that.
be careful. Alright, anyway, back on subject here. Su- No, do not rip it off like a Band-Aid. Supine, don't tear the skin. Supine on the table, we're gonna put them in that specific oblique, RPO, LPO, there'll be a 35 to 40, another different oblique range, guys. It's a lot of these oblique ranges that are difficult to remember. You make yourself a little chart on those. They vary quite a bit, so 35 to 40 degrees. You'll make note that nothing in this chapter has really been 45 degrees. So when you see it on your test on Thursday, do not select 45 degrees for these obliques. Oh, I'm gonna do that because the registry does that.
Who's gonna do?
So rotating 35 to 40 degrees.
Gonna put 45.
Now, once in position, the physician is going to insert the contrast medium, and either the physician or you will extend the penis to obtain uniform density. You have to extend it and place it on the thigh if the patient cannot do so for you. Yes, you have to do that. You will then expose while injecting the contrast to ensure the entire urethra is filled. And what are we going to look at? The superimposed pubic and ischial rami of the downside and body of the elevated pubis anterior to the neck of the bladder. But the big star of the show will be the proximal urethra. That's the main area we're focused on. I should put that in a different color red. Proximal urethra. And actually they evaluate the prostate on this exam as well. They can see if the prostate is swollen or infected or something going on there, or constricting the urethra on that prostatic urethra specifically. Y'all remember the 4 parts of the male urethra, by the way? Prostatic, membranous, bulbous, and spongy or penile. Spongy or penile, 4 parts. Female urethra is what? Just short urethra. Very simple. That's it. And that's what we want to look at, like guys. That's why we place the penis on the thigh, because we're actually seeing the urethra through the skin. Now you want to put it on the thigh and not in the middle of the leg, because that's not going to work out for you. You want it on the actual soft tissue of the thigh. So we're going to see the superimposed pubic and ischial rami of that downside, as what we see right here. And body of the elevated pubis anterior to the bladder, neck, proximal urethra, and prostate, which would be right around here, that prostate. And you can actually see right here, the prostate is constricting the urethra slightly on this patient. It's very thin right here. Should be a little more wide, like you see over here. So prostatic urethra, membranous urethra, bulbous, and here's that spongy penile urethra before it exits the body. So people don't realize the urethra goes that far back into the body, because this is the testicles right here, if you want a reference for where we're at. So that urethra goes way far back.
Bulbous is the.
Where it curves with that sharp curve, yes.
That curve looks very yours. Where's the curve?
Right here.
Okay. And this is the only position we do for men.
This is the only position for this exam. Because we're not going to cheat, we're not going to be able to really see what we want to see if it's just plain AP or lateral. It has to be that specific oblique.
It has to be our.
It can be RPO or LPO.
RPO or LPO.
Either way. So when you finally mention tape, that actually might not be that bad of an idea, because if the doctors have them go back and forth, it's going to cause an issue, or have them slide around. So tape actually might work very well.
If it doesn't reach all the way to the top.
Oh.
You can still make it work.
Reagan,
You can.
my child was never going to get X-ray paid. Just in case. I do have sons.
I mean, if it doesn't reach the thigh, I mean, still put them in the oblique. I mean, you can still get a semi-good result.
Reagan said, no, thank you. We will go somewhere else.
Yeah. Oh, I have 2. There will be your LPO. That was the RPO. There's your LPO. And this placement, not very good. You want the placement to be along the thigh right here. So, naming the parts again, guys. This is a very ugly picture, by the way. Bladder, prostatic urethra, membranous right here, bulbous right here, penile or spongy down here. All right, so for female cystourethropgrams, why would they need this done? Tumors, abscesses, diverticula, dilation or strictures, and that's also going to usually precede an endoscopic exam. Also, just very serious urinary tract infections, they'll do these as well.
Strictures.
Stricture is when it's narrowed.
Okay. Dilation or stricture.
So for females, after a physical cystoscope is removed, Catheter will be inserted into the bladder. Bladder is drained just before you inject the contrast solution. And it's simple as that. So for females, you don't need to put them in an oblique. You just keep them AP. Because the female urethra is very, very tiny, very short. You can see it just fine on an AP exam. Just make sure that doctor's putting everything in the right spot. I've seen doctors screw that up too on female patients. They're not as smart as they think they are.
Sorry.
Usually you'll be the one doing the catheterization for these beforehand, depending on where you work. All right, so supine exam. You can be supine or semi-seated for the female. IR at the level of the superior border. Central ray, if needed, guys, if they want to free that bladder neck a little bit more, which you usually don't need to, it's so short anyway. You have the choice of using a 5-degree caudal angulation, but that's optional. It's a very slight angulation to extend that neck a little bit more. Once again, caudad to make sure that pubic symphysis is out of the way as much as possible. All right, so while obliques are not required for the females, if they do request it, which is very rare, and usually they can see everything fine on the AP, they're gonna do it the same way as the male, 35 to 40 degrees, exact same way. And that will actually move the urethra more posterior to the pubic symphysis, giving a little bit of an extra view of that area if there's something going on. And the upper thigh will be extended and abducted to prevent overlapping as well. So bladder will be filled up. And one thing I didn't mention once again, guys, when they do this exam, they're gonna have that catheter in there. They're gonna fill that bladder up with contrast, do the x-rays, do the views like the APs or obliques. Then they're gonna remove the catheter and ask the patient to urinate on the table. Because they wanna watch all that contrast come out of the bladder, go through the urethra, and make sure it empties correctly. So this is the ones in particular you wanna make sure you have lots of towels nearby, because you're gonna have a huge mess on the table if you do not do so. So what I do, I always make like a little fort, a towel fort around the patient. I call it my towel fort. I encircle the patient with all the towels. That way when they're peeing on the table, it kind of just catches it all as it makes the puddle. And then I just wipe it up when they're done. You look all disgusted over there. It's just contrast coming out.
But why can't they, if the patient is in good condition, why can't they just use a bedpan?
Because it would get in the way of what they're trying to see. They're going to actually fluoro while they're urinating.
Okay.
That's
I
why
thought
it's
they just wanted to
avoiding
see
study.
them
They're going to, huh?
pee. I just thought they just wanted to see them pee, like just pee.
No one wants to see them pee, but
R. Kelly would. Hey,
uh,
I saw my shot and I had to take it.
anyway, get lots of towels. It's going to save you a lot of headache because there's actually a danger to that, guys. We work with a lot of circuitry. So naturally, if they're peeing a lot and it's falling off the table, it's going to get into the circuitry of the table. And guess what they have to do? Shut the whole room down, sterilize, and sometimes replace the equipment because you just fried it all with urine. I've seen that happen too. Someone didn't put towels down, kid peed all over the table, it leaked inside the table. They had to dismantle the entire room and replace all the circuitry. Yeah, true story. So towel fort, don't forget the towel fort. It's not in your notes, but great idea to have extra towels.
So, what was the step again? Like you take out the cystoscope and then you
So,
put in the catheter?
You take out the cystoscope, that's after they scope and look inside. They're gonna put the catheter in, fill it up with contrast, usually by hand injection. They're gonna fill that whole bladder up. They're gonna do some rotations and some views. Then the doctor say, this time we're gonna go ahead and remove the catheter. As soon as I remove the catheter, I want you to urinate on the table. They'll pull the catheter out, and hopefully the patient will start peeing on the table. They'll keep the fluoro going as that bladder empties onto the table.
And they were supposed to have an empty bladder before this?
They should, yes. So they should urinate beforehand. Absolutely. Otherwise you have a bigger mess on your hands. Better cleaning up contrast than pee all over the table. And that's what it looks like right there for your female cystourethrograms. Much smaller area of interest. Bladder and urethra. Simple as that. and this is just plain APs. Like I said, the obliques would be optional for the female.
Why does it look right at the very end?
Right here? That's a good question.
Like, does she, no, does she have catheters? No, right?
I don't know what that is. I'm not sure. I don't know. By the way, this is a pediatric. Can y'all tell?
Yeah, cause the bones and stuff.
Yeah.
The joints are super open.
Right here?
Mm.
Right here? Very common in pediatrics. We do lots of these in pediatrics. A lot of children are born with major issues with their kidneys and bladders.
That is actually true, I thought it was.
Do tons of them.
Yeah, the
Almost
surgery they
daily.
don't mean is mostly done on kids.
And little girl babies get UTIs really bad
Yeah.
all the time too.
I've done so many different.
All right, guys. So let's do a few review questions, and then we'll take a break and do the review game to wrap this all up. So IVU exams are used to evaluate all the following except what? Except what?
Big.
Trauma.
Only one of those will make sense for not fitting,
B.
because it's actually naming an entirely different exam. It's a key word in there.
Okay.
One of those answers is talking about a whole different exam.
That pyelonephrosis.
No,
Oh,
pyelonephritis is
D.
a swollen
D is in
pelvis,
Oh.
Dog.
swollen renal pelvis.
Yeah.
D.
Yeah,
Why is
D.
D incorrect?
Kidney
Because
function.
what's a
So that's
post-lithotripsy? What's a lithotripsy?
That's
About
when they go break
breaking
the
down the
kidneys.
stones.
That's where they specifically
Kidney
break up
stones.
kidney stones.
Oh, yeah.
So we're not doing IVU for that purpose. So post-lithotripsy for kidney function. All right, what position is used for the AP oblique of cystourethropy for a male patient? We just talked about this.
C.
35 to 40 posterior oblique, very good. Very great example question for your test, by the way. I told you I won't put that 45 in there. Don't go to that 45, I know it's our default, but do not select 45. 35 to 40, posterior oblique. Which kidney, oh, this is a good one here. Which kidney is placed in parallel to the IR in the AP oblique 30-degree RPO position? Very good, y'all remember, very good. The left. The left will be parallel. Which one will be perpendicular?
Right.
The right. Excellent. Excellent. Projection anatomy, guys. What is this?
This is the
This is an exam you're not actually going to do. I don't know why this is in here.
It's a right lateral.
That's A.
Because it's a right.
This one will tell you that. It's a right lateral urinary. You're not actually going to ever do this projection for a IVU. I don't know why they put that in there. I apologize. But can you see the kidney
Mhm.
and the ureter just barely?
Mhm.
You would never do this for an IVU. How about that one? We can name what that one is. What is that?
AP axial.
It's not that.
C.
It doesn't seem like axial. It's like AP, urinary bladder.
So remember, we have two different ones when we talk about the cystograms. We have a regular cystogram and we have an avoiding cystogram. That's our first clue.
I think it's in the urinary.
Oh, just B.
So I didn't show this. I didn't show this to y'all when we were doing the slides, guys. But it's an AP.
Oh, just B.
Reason being because of the shape of the bladder. See how it's more oval inside like this, like a wide oval shape. If you see a wide oval shape, it's regular AP. If you see a long oval shape, that's when your angle's on there. I didn't make that clear earlier. But look for the long oval shape to indicate there's an angle on the tube. If it's wide, like you see right here, that's a regular AP. That's the best way you can tell. Make sense?
Wait, so why do you need the ankle then for the axial? Because
If you need to bring this down further and elongate the bladder, especially the neck of the urethra right here.
So I have a question.
Move the pubic symphysis out of the way, but you could clearly see the whole bladder without moving it out of the way.
It depends on the patient. It does depend on the patient. You have a question?
Yeah,
Yes.
cause this picture is kind of similar to that one, and it says AP axial.
Does it?
Yeah, you wanna come look, come.
Give me a second. I'll look at it in a second. We're about to do a break. Leave that page open.
Okay.
Make sure I didn't make a typo. What is that one? Boy, this is a really good question here.
Well, you like that one.
I love this one. That's a pretty image.
It is.
That's a great one for labeling, I'll say, for hot
It's just,
spots.
let's see.
See?
That's just an AP urinary. Why? Because, well, we don't do PAs, and it's obviously not lateral. That's common sense, so it has to be AP. Great labeling image here, guys. I'm gonna say it again. Great labeling image for a hot spot exam. If I do say so myself.
Good to know, good to know.
What is this?
That's B.
So here lateral. It's definitely, obviously, a lateral. But how do we know it's a left lateral?
Little markers in the
I
right
hope this all
though.
Markers in the right.
Yes. Seems like common sense, but people overlook this stuff way too much. What about this one? This is
RPO.
Boy, it's a good one. We'll like this one.
This is C.
It's not RPO.
How do you know it's RPO and not LPO?
Cause the
It needs
marker and then
perpendicular.
the Scotty dog.
Sky dogs and the marker placements. You always mark the side down, side's touchy,
And the olive.
so it has to be, and the olive's very good.
So what is
Y'all
that-
remember y'all's obliques? Good.
What is that
Proud
over
of y'all.
the, body? Is that like a compression thing?
It is. You remember what we talked about?
Uh-huh.
We talked about compression belts.
Yeah.
Is
So
that
that's
your
what it,
ureteral compression belts
Okay.
to slow down the flow? And last one, guys, what is that? Pretty obvious. AP oblique urinary bladder. As y'all can see, it's oblique, right? Y'all see that? Good. All right, guys, take a quick break. Take a quick break, and we will pick back up in 10 minutes, 2:18, and we'll do our review game I have for you. 2:18. You see that picture? Because I'm already glancing. This is obviously angled right here. Yeah, AP axial.
this one.
That's not angled because this is normal. And what's funny is that that image I gave you is straight from the book as well, and their notes on there have it as an AP. These are regular APs. Okay, I want to look further into that, because the PowerPoint labeled it as regular AP
Mhm.
so that is the exact same image I
Yeah.
showed you. Okay, let me check and see. Because in general, whenever the bladder shaped in this fashion, it's a regular AP. When it's elongated more like this,
Mhm.
it's axial, which they do have it labeled
Oh,
axial
yeah,
there.
they got it, oh. Mm-hmm.
I'll check that out.